Colorectal cancer, early detection saves lives. Coming up next on Call the Doctor.
You are not alone.
Call the doctor.
Call the doctor.
Call the doctor.
Did you know that colorectal cancer is one of the top 4 cancers diagnosed throughout our region? Rates are 10% higher in our area than the national average. Colorectal cancer starts in the colon or rectum, which are parts of the large intestine or the lower part of the body's digestive system. Colorectal cancer often begins as a growth called a polyp, which may form on the inner wall of the colon or rectum. Some polyps become cancerous over time, so removing them can be a good step toward preventing this type of cancer. It's important to be aware of potential signs of this cancer. Some of them include a change in bowel habits, blood in the stool, diarrhea or constipation, frequent gas pains or bloating, feeling exhausted or vomiting. But because there are often no signs in the early stages of this disease, it's important to get screened. When caught early, colorectal cancer is highly treatable, and deaths from this disease have decreased due to detection techniques like colonoscopies, fecal occult blood tests, sigmoidoscopies, and more. And remember, a healthier lifestyle can also help prevent colorectal cancer. It's important to avoid smoking, watch your weight, exercise regularly, and eat more fruits, fibers, and vegetables. Welcome to Call the Doctor here on WVIA TV. I'm Paula Giacomo. Tonight, our topic is colorectal cancer. Joining us on the panel are Dr. Thomas Erkinger, colorectal surgeon from Geisinger Wyoming Valley Medical Center in Wilkes-Barre, Dr. Samuel Leshko, medical director, Northeast Regional Cancer Institute in Scranton, and Dr. Aman Ali, gastroenterologist from Digestive Care Associates, PC, in Edwardsville. He is also on staff at Wilkes-Barre General Hospital and Gateway Surgery Center. I would like to remind you, the audience, that viewers at home can participate by commenting along with the conversation at wvia.org/CTD. You can also submit your questions for future shows by emailing ctd@wvia.org or using the hashtag WVIACTD. Check our website for a listing of future programs. Now, let's begin the discussion. Thank you, gentlemen, for joining us for this very important topic, colorectal cancer. It's fitting that we're talking about this because March is Colorectal Awareness Month. And one of the most important things people could do is get screened. You are, Dr. Ali, that's what you do for a living, endoscopies. Can you stress the importance of getting screened for colorectal cancer, and at what age should someone start screening for colorectal cancer?
Thank you for having us here. It's a very important thing to emphasize on, and for health of our nation and our people. Colorectal cancer, as you know, is one of the leading causes of mortality and morbidity throughout our country. And at this point, what recommendations are, the guidelines are to get screened at age 50, whether you're man or woman, at age 50 for an average risk person.
What if it runs in your family?
So, that's why the term average risk. If it is a patient population where they have higher risk for colorectal cancer, and there are a variety of different disease conditions which increase the risk of cancer, as well as the strong family history or family history. In that situation, it would be wise to start screening earlier, and there are set guidelines and rules for that.
Now, Dr. Leshko, a lot of people are hesitant or scared about getting a colonoscopy. Why is that, and how can you calm their fears and, again, stress the importance of getting tested?
Being afraid of the test, sort of taking the view that if it ain't broke, I'm not going to fix it, is the wrong attitude here. Because colon cancer is different from other cancers. If we detect it early, we can improve the chances of responding to treatment, and especially if we detect a precancerous lesion on colonoscopy, that can be treated And that's a cancer that's prevented. And we can't say that our screening strategies prevent most cancers. That certainly is true for colon cancer, and that, if no other reason, is one important reason why we should take screening seriously. Everybody should be screened for this, beginning at age 50, or maybe even a little bit younger.
Yes.
And Dr. Erchinger, what are we looking for in these tests? Polyps?
Lots of abnormalities can be found on colonoscopies. What we believe that most colon cancers arise from a polyp, a benign polyp initially, and so that is what we look to find and to remove at the time of colonoscopy. Back to the earlier question, why don't people want to do it? What are their barriers to having a colonoscopy? It is an invasive procedure. There's no doubt about that. And my opinion is that we just need to get over that. We see our physicians, our doctors, our primary care providers for lots of issues, and it's very personal. Your medical care is personal. But I think that's probably the biggest barrier. That
Can you describe the test for maybe viewers who haven't had it yet or they're thinking about getting it? Can you describe what is entailed in a colonoscopy?
Well, in order to get a good view of the colonoscopy, it requires a prep, and so that's another thing that sometimes people are a little bit afraid to get. You have to drink a solution or take a medication to clear the colon out. There's no way to get a good view and to find those small polyps without doing so. So a prep's required the day before, and then we usually don't want you to have anything to eat or drink after about midnight. The actual procedure, most patients don't remember anything about it. You use sedation for the procedure. Often an anesthetist, an anesthesiologist will be involved with that.
So you're knocked out for
a
short period of time.
Yeah, right. And like I say, most patients don't even recall the procedure or having come into the room. And so you are kept comfortable during the procedure, sedated well, and so really, and the other thing, complications of colonoscopies are exceedingly rare. When we remove polyps, larger polyps, there are potential for problems, but they're rare, and most of them don't require any further intervention.
So during the colonoscopy, if you find a polyp, do you then have to biopsy that polyp, or can you remove it during the colonoscopy?
Most times it's removed.
Okay.
If it's a larger polyp where it might be unsafe to, it might just be biopsied. But even now, today, Aman is experienced in doing more advanced procedures to remove larger polyps where we might not have been able to just a few years ago.
Okay. Well, during our shows, we're taking email questions from viewers, and we have an email question right now. This person asks, what is a virtual colonoscopy and how does it differ from a traditional colonoscopy, and what are the advantages and disadvantages? And this question comes from Doris in Tannersville, Pennsylvania. Dr. Ali, could you address that?
Yeah, it's a good question. Virtual colonoscopy is essentially a glorified CAT scan. And as you know, a lot of time we will do a CAT scan for finding various abnormalities inside your body, and particularly in this case with abdomen. Patients having abdominal pain and so forth, you'll get a CAT scan. This is a special CAT scan in a way that patient has to undergo the same preparation as he or she would undergo for a colonoscopy. So for the day before the test, they will have to have some medicine, a laxative to clean their colon out, and they will have to have a modified diet, all the precautions you take before undergoing a colonoscopy. But instead of undergoing anesthesia and having an invasive procedure where a colonoscope is used, a camera is used to visualize the inside of your colon. A radiologist will inflate the colon with the help of air and with some contrast, and they use the CAT scan to visualize the colon.
Okay. Is this test more effective, or is it the same as a traditional colonoscopy?
So the test has a lot of shortcomings, and there is a bias. Obviously, I'm a gastroenterologist. I perform colonoscopy, so the gold standard always will be colonoscopy in my opinion. But there is a consensus amongst gastroenterologists and surgeons that when you do find something equivocal or not clear on virtual colonoscopy, you have to undergo a real colonoscopy. So in my mind, it's many times a exercise that makes the patient undergo two different times of anxiety and testing and so forth. So In our practice, we use it only in situations when, for some reason, it is difficult to traverse the colon with traditional colonoscopy, and it's reserved only very few cases. So to give you perspective, we might do, at our center, we do 5,000 to 6,000 procedures. We may be ordering 10 or less than 5,
virtual?
5 to 10 virtual colonoscopies.
And you were also saying that there's advancements that have been made in the type of camera that is used in the traditional colonoscopy, so it makes it even better to be able
Right.
to visualize the polyps.
That's correct. So just as we have high definition movies and DVDs we see the picture qualities are getting better and better and better. Our cameras now have high definition capabilities to see, visualize, inspect colon in much better way. They have capability and special optical filters available to visualize early and very flat and difficult polyps or lesions which were otherwise not detectable previously. So there has been a lot of advancement in that area.
The clear difference between the virtual colonoscopy is in order to make a diagnosis, you need tissue. And once you find a lesion, even if you find a lesion on the virtual colonoscopy, you'll then need to have a colonoscopy in order to remove it and biopsy it.
Now, during the colonoscopy, let's say you find a tumor, something bigger than a polyp. I mean, when do you make the decision to have surgery?
Well, again, it depends on the biopsy and the histology, or if you diagnose a cancer within the lesion, then virtually all of those, the patient being an appropriate candidate, would be treated with surgically. Occasionally lower, if a large polyp with a small cancer that's in, say, the head of a pedunculated polyp, that could be treated just by removing the polyp. But any colon or rectal cancer that's been diagnosed generally requires a surgical procedure to have a resection.
Okay, let's say someone goes in for a colonoscopy and the results are clean, but then somewhere down the line they start to develop some sort of symptoms. What are the symptoms of colorectal cancer? Dr. Leshko?
Well, I think you've already mentioned those on the lead-in. Change in the bowel habit, blood in the stool, maybe a change in normal bowel functioning, so recurrent diarrhea or crampy abdominal pain, change in the caliber of the stool is one. Signs or symptoms of anemia, fatigue, paleness, all can be signs of colorectal cancer. Maybe the take-home message here is that if I've had a normal screening test 4 or 5 years ago and I now develop symptoms, I shouldn't just assume that it can't be colon cancer. I should bring that up to my doctor and perhaps be investigated again. It would be a shame to overlook that and have the tumor grow and be more difficult to treat, possibly impossible to cure. So just having had a test in the past doesn't give me immunity from having this disease at some point in the future.
How often should you get tested?
The standard recommendation for colonoscopy is every 10 years, beginning at age 50, earlier if you have a strong family history or if you're in a high-risk group like African American, and then every 10 years. There's been some discussion about whether populations like ours in Northeast Pennsylvania with a higher than average risk of colon cancer would benefit from having more frequent screenings. I'm not sure that that's justified. I think every 10 years is fine, but don't miss it, don't forget it. And what I think is most important is that everybody have at least that first one at age 50, and then I would strongly argue to continue screening at 10-year intervals until age 75 or 80 or thereabouts.
Can you get screened more often than that if, let's say, you're showing some signs or symptoms?
So the guidelines have been quite clear about that. If we do find a polyp in a patient and the histology of the polyp shows that it's what we call tubular adenoma, depending on the size of the polyp, if it's less than 1 centimeter, we will usually recommend a colonoscopy in 5 years. If we found 3 polyps which were tubular adenomas, then we'll recommend a colonoscopy in 3 years. Whereas if we found something called hyperplastic polyps, which are completely benign polyps for particularly the lower side of the colon, we could still go ahead and do the colonoscopy in 10 years. So it is an individualized care that you have to give to individual patient. And so there will be patients who will be on a surveillance protocol for every 3 years, other will be every 5, and so forth. There are 2 additional points, just as we were discussing earlier. There are select advanced techniques like endoscopic submucosal dissection is one of the higher end techniques where you require meticulous dissection of very early stage cancers, and yet you still be able to save a patient from having surgery. So a very flat early polyp, early cancer, colonoscopy can be a powerful tool in the right situation as well. So you don't always have to have surgery, although I agree for the most part when it's a invasive cancer, surgery is needed. And the second thing that I wanted to mention, a lot of time patients will assume, as Dr. Leshko's touched, that, well, I had a colonoscopy already. And similarly, one of the biggest barriers I see in my clinical practice, that they will assume that it's hemorrhoids or something just okay to happen, and they do not mention it to their primary care doctors. When they're going to see their primary care doctor, they're talking about diabetes, blood pressure, all the other things, cholesterol. But when it comes to the bowel habits, or a little blood on the tissue paper or blood in the stool, they're not forthcoming with mentioning those symptoms. And
You might be embarrassed to talk about it, but it's very important to discuss.
And in a lot of clinical situations, we have seen hemorrhoids were otherwise the shield the colorectal cancer was hiding behind for a period of time before we finally unveil it.
So colorectal cancer, even though it is the second leading cause of cancer deaths in the U.S., it is preventable, is it not, Dr.
Absolutely. If we, with appropriate screening, we can catch them before it becomes a cancer, at that polyp stage, the tubular adenoma. And if we remove it at that time, and we can prevent the colon cancer.
What else can we do in terms
Well, there
of
are also
lifestyle?
things that we can do to reduce risk. That's not an absolute prevention, but we can reduce risk by maintaining a healthy weight, eating an appropriate diet, and the best diet for colon cancer prevention is going to be one that is a high fiber diet, rich in fruits and vegetables, less emphasis on red meat and processed meat, so hot dogs and summer sausage or bologna,
Foods with nitrates.
the nitrates in particular, right? Also, the way we cook our meats might increase risk. So that really crispy bacon might add an increased risk.
Or charred foods.
That's exactly right. There are some mutagenic chemicals that are developed in that cooking process, and so avoiding those would be important. Other things to do are maintain a healthy weight, exercise regularly, know your family history, and share that with your primary care doctor. As I was thinking about earlier, family history is not a static thing. It can change. And so if my family history has changed in the past year, when I see my primary care doc, I should update them and say, by the way, my brother had a problem, or I learned that my father had colon cancer that I didn't know about before.
Mm-hmm. What about, we have another email question from Cynthia F. from Lewisburg. She wants to know, what are the different stages of colorectal cancer, and how does each stage determine the treatment approach? Is being diagnosed with stage 4, is that necessarily a death sentence?
Well, the stages, we have stage 1 through 4, and stage 4 is definitely not a death sentence. It is very treatable and sometimes curable still. Stage 4 means that it's spread to solid organ outside the lymph nodes and outside the primary tumor. But with appropriate treatment and reassessment, even metastatic or spread to the disease to the liver or the lung can be treated potentially surgically with a cure. And so it is an important thing to evaluate these patients, treat them, and offer treatments that can potentially be curative. Back to the screening, it is important that we catch it as early as possible. Stage 1 disease, where it's confined to the colon or to the rectum, can have a 90% cure rate. Unfortunately, we don't catch only less than 40% of patients may be found at the stage 1.
So there's a 90% cure rate if you catch it.
Right.
Which is why screening is so important.
Right. Stage 2, where it's a little bit deeper into the colon wall, still has about a 70% cure rate. Stage 3, where it's involving lymph nodes, is much less. That's in the order of 13 to 20%. And then stage 4 obviously has a poorer cure rate, but it still is treatable and potentially curable. There's lots of changes in adjuvant treatment, chemotherapy, for managing colorectal cancer in more advanced stages, and that treatment has been very successful. Recent changes with immunotherapy, in hormonal therapy, as well as standard chemotherapy, has been very successful.
That's great. Any other, I'm sorry.
Well, I think it's important to note that the population here in Northeast Pennsylvania has access to all of these kinds of treatment. You don't need to necessarily go out of town to get high quality surgical care, gastroenterology care, medical oncology, and even radiation oncology care locally.
And colorectal cancer is high in Pennsylvania, especially this region, isn't
It
that right?
is, and so I think that's a reason to emphasize that we need to be aware of it, to talk to our doctor about screening, be screened if you've not been screened, know your family history, share that information, and stay on top of this.
Dr. Ali?
As opposed to many other cancers where we don't really have a mean to make a big difference in the patient's health and cure rate, here we have a pretty long window of opportunity where we can act and nip the evil in the bud, if you will. I mean, as opposed to, for example, pancreatic cancer or some of the brain tumors, you don't have that window of opportunity, and one day you're just diagnosed with a very ominous cancer. In colon cancer, when the symptoms do develop, it's already made into a cancer, but you have this long time of period where precancerous conditions can be detected, and the access to the colon is very easy and safe with colonoscopy, even though it's an invasive procedure. But a colonoscopy procedure can be done with much more safer techniques now compared to what it was. The better cameras, better techniques. There are new advances. We learn every couple of years. We change our practice accordingly. There are techniques which have been advocated as painless or minimum insufflation colonoscopy, where you use water or saline to inflate the colon, minimize discomfort. Patients are, as you mentioned, are sedated for the procedure anyway, so they don't feel anything. So harder part of the procedure is the day before, getting that liquid laxative and preparation done.
And the anxiety just thinking about
the
procedure.
what you're going to find. And,
that's probably the hardest part for patients.
But the actual procedure in our practice.
How long does it take from start to finish?
So it varies from patient to patient, but on average, I would say 15 to 20 minutes would be adequate time to do colonoscopy. There are guidelines set in place that you have when you're coming out from the end of the colon, you have to examine the lining of the colon for at least 6 minutes or above. But on average, I would say 15 to 20 minutes average risk screening colonoscopy exam can be completed very easily.
Are there any risks going through this procedure?
There are certainly risks to anything. The risks increase when you need to do a biopsy or removal of polyp, bleeding, and potentially a perforation of the colon. But as we mentioned earlier, those are exceedingly rare. Patients are sedated well, so discomfort is usually pretty minimal, and like we said before, they often don't even remember the procedure.
Dr. Leshko?
Well, I was just going to say that there are some risks, but the benefits in this case clearly outweigh those risks, and that should not be a serious deterrent from being screened. Currently, only about 2/3 of adults are screened appropriately for colon cancer. It'd be nice to get that up to about 80% or higher, and that's particularly important for us here.
Especially now, since it's Colorectal Cancer Awareness Month, and screening is key. Well, we thank you for joining us. This was a very lively and informative discussion. I'd like to thank our panelists for participating in our discussion on colorectal cancer. For more information and to continue the conversation, visit wvia.org/CTD. I'm Paula Giangiacomo for Call the Doctor. Thank you for watching.